Okay, hello everyone. This is Qasim Aziz. I'm Professor of Neurogastroenterology at the Wingate Institute in London. And I'm going to talk about investigations and medical management of EDS. So just to really orientate everyone, if you've forgotten what your science lessons and what your gut looks like. So here's a description. So our gastrointestinal tract actually starts at the mouth, and after the throat, which is called the pharynx, it actually joins this food pipe called the esophagus or the gullet, as it's described sometimes. And then at the lower end of the esophagus, it meets the stomach, and that's described as the gastroesophageal junction. And there is a valve there, which is usually shut down to stop any acid or stomach contents to come up into the esophagus. But when we eat, it opens up. And in some cases, this valve is a bit weak, and that provokes acid reflux. Then the globular organ just underneath this gastroesophageal junction is the stomach. The stomach is a mixer. It mixes the food with the stomach juices, particularly acid, to clean up the food and churn it into small pieces. And these small pieces then are slowly moved down to the small bowel, or the small intestine as it's often called. This is where absorption of food and nutrients occurs, and everything that is left behind is the waste, and that then goes into the large bowel. Usually there is a lot of fluid as the food comes down into the large bowel, so the fluid is gradually absorbed as it makes its way through the bowel, and then the stool becomes harder and harder till it arrives in the rectum, and you get a cold stool, and then you can evacuate it. Now, in patients with EDS, you can get problems in the entire gastrointestinal tract, and these problems are often related to motility, movements of the gut, but they can also relate to sensation. So movements can be affected, and the gut can be more sensitive. So the symptoms that patients often present with, as I also mentioned in my previous talk as well, nausea and heartburn are very common symptoms in our patients. Bloating as well is very common. But indigestion, in my experience and in the data that is available, often described as dyspepsia. There are two types, pain in the upper tummy or fullness after meals is a very common presentation. The most common presentation is abdominal pain, and then you can get alternating bowel habits where bowel movements move between constipation and diarrhea. So when we think about problems, gut problems in EDS, I like to divide it into three areas: mechanical problems, where the movements are effective; sensitive gut, where there is more pain; and then the third one, where the jury is a bit out as to whether this really is a cause of symptoms in EDS patients, but looking at the mechanisms of symptoms in other disorders like irritable bowel syndrome and functional dyspepsia, leaky gut is quite common in those conditions, and it is suspected that this may be the case in EDS patients with gut symptoms as well. So when we come to mechanical problems in the esophagus or the gullet, if the movements are very sluggish, that can produce difficulty with swallowing. Often in clinical technical terms, we call it dysphagia, but that basically means that food or fluid can stick in the esophagus as it moves down, and that can be quite uncomfortable. And as I mentioned, the valve at the lower end of the esophagus, if that is weak, that will produce acid reflux, but you can also get regurgitation of food and fluid from the stomach into the chest cavity. And if your stomach is too sluggish, then that will produce a delay in the emptying of the stomach, often described as delayed gastric emptying. But sometimes there is a group of patients, particularly with POTS, who have rapid gastric emptying as well. And both delayed and rapid gastric emptying can produce different types of symptoms, but pain, discomfort, bloating, early satiety, which means that you get full very quickly after a meal, are quite common symptoms. Small bowel, as I said, this is where food is absorbed, and you can get malabsorption if you are not absorbing food properly there. And this happens in conditions like celiac disease. But bacterial overgrowth, especially if the motility is slow, because of stagnation, you get unhealthy bacteria in the small bowel. And these bacteria can cause fermentation of food, particularly carbohydrates, which causes quite a lot of bloating and discomfort and cramping, abdominal pain. But it can also cause these unhealthy bacteria can cause malabsorption of fat in the small bowel. And that then produces oily, fairly foul stools. And that is because of malabsorption of fat. This can lead to malabsorption of fat-soluble vitamins sometimes. And if the large bowel is very slow, then you'll get constipation, but you can also get diarrhea and sometimes overflow diarrhea, which is what I described in my previous presentation. And then just towards the end in the rectum, you can get rectal evacuatory dysfunction, which can sometimes just be because the pelvic floor muscles are a bit weak and they do not move strongly enough to cause an evacuation, or sometimes they can be a pouch in the rectum called a rectocele, or a prolapse inside in the rectum called an intussusception, and I've described these in my previous talk. Then we talk about the sensitive gut, and there are a few different mechanisms which can lead to a sensitive gut. You can have nerves in the lining of the gut becoming very sensitive, and this happens if there's been some sort of injury or inflammation in the lining of the gut. This makes the nerves quite sensitive. So the analogy would be if you drop a bit of hot oil on your hand while you're cooking, then the skin on the hand becomes a bit sensitive afterwards, and that's because the nerves there on the skin have been a bit damaged, and that causes a sensitization. But if this injury is very severe, this can lead to sensitization more at a central level in the nerves in the spinal cord, and this is described as central sensitization. The important thing to remember is when the nerves in the level of the spinal cord get sensitized, then this can last for quite a long time. Even though the original injury is healed, the nerves can stay sensitive. But of course, your psychological profile, the anxiety, stress has an effect on all of this. And even if you have got inflammation, injury-related sensitization, the pain can be made worse when you're under stress. We talked about the effects of a leaky gut, and the theory is that if you have a leaky gut, then a lot of food particles, drug particles, etc., can get through the lining of the gut, and this can cause a intestinal barrier dysfunction, and the immune system underneath, particularly the mast cells, they get activated, and that can lead to a lot of food allergy intolerances, but immune system abnormalities and even autoimmune diseases can occur because the gut has become quite leaky. But in terms of EDS patients, the relevance is really around food allergies, food intolerance, and mast cell activation. Now, POTS patients often can become very symptomatic, and I've talked about this before as well, but I bring it up again because I think this is a very common problem and not very well understood. And POTS patients, when they can complain of tummy discomfort after meals, nausea, but they also complain that their POTS symptoms get worse after a meal. They can become more dizzy. Sometimes they feel very sleepy after a meal and can't sit upright and have to lie down. At a very simple level, there is an increase in blood flow when we eat, and the blood vessels expand. That means that there is more blood trapped within the tummy cavity, and if you're already running on a very low blood pressure, that can lead to further drop in blood pressure. Your heart rate can go up, and you get worsening of your tachycardia, of your POTS symptoms. But there can also be this, as I've described, lightheadedness, fatigue, drowsiness, fainting, nausea, bloating, etc. that can occur. Now, in terms of management of problems that our EDS patients complain of, the general approach is to generally reassure patients, just to let them know that we understand that EDS patients can experience these variety of problems, and that in its own right can be helpful to patients in whom the association of gut problems in EDS has hitherto gone unrecognized, and explanation of why they have multiple symptoms and how these symptoms link in with all the other problems they're experiencing in their joints and their muscles, possibly even urinary tract problems and mast cell problems, etc. So it helps to understand why all of this is occurring. It's ideal to have a multidisciplinary approach with colleagues getting together to manage patients, because we often need help from dietitians, pain management consultants, colleagues who understand POTS, joint problems, and urinary involvement. Is very important to have a group of senior colleagues who can help treat these problems, because if you pick up in your patients who predominantly presented with a tummy problem that they also have POTS and joint involvement and bladder involvement, then it's useful to be able to refer them. And of course, chronic conditions can produce quite a lot of stress, and having the help from a good psychologist can also be quite helpful. It is important to exclude other causes, because EDS patients can suffer from other diseases as well. And some basic screening is required, which usually it takes the form of blood tests, X-rays, scans, which can be ultrasound scan or MR or CT scan, and endoscopies, just to make sure that nothing is missed. In the literature, there is an overlap that has been described with inflammatory bowel disease, celiac disease, autoimmune connective tissue disorders. And of course, we have to be aware of the red flags of anemia, which could be due to iron deficiency or other vitamin deficiencies like B12 or folate, weight loss, swellings that you can identify when you examine the tummy, or a recent change in bowel habit. If you have any of these red flags, then we need to investigate the patients quite thoroughly to make sure nothing is missed. If we do not find any objective anatomical problem with the gut through all the scans, etc., that we've done, then it's often worthwhile doing motility tests to see if there is a problem with the function of the gut. And this is where GI physiology investigations like esophageal manometry and 24-hour pH monitoring, where we can measure not only the movements of the esophagus when our patients swallow, but we can also see how much acid and bile reflux comes up in the esophagus over a 24-hour period. A stomach emptying test, where we give a meal and then we see how quickly that meal empties from the stomach, can give us an idea as to whether there is a slow or rapid gastric emptying. Hydrogen and methane breath tests to diagnose bacterial overgrowth, but also can be used to diagnose lactose intolerance and fructose intolerance. There are colonic transit studies that we can do, which involves giving patients some radiopaque markers and then taking an X-ray 5 days later to see if they've cleared those markers or not. And anorectal physiology studies to diagnose the possibility of a rectocele or a evacuation disorder due to pelvic floor muscle problems or a prolapse. And there's a range of anorectal physiology methods which involve both motility measurements, but X-rays as well, like proctograms, etc., which can help to diagnose these problems. Food intolerance is very commonly reported in our patients, and quite often by the time they come to us, they are on a variety of diets, and wheat avoidance and gluten avoidance is perhaps one of the most common ones. FODMAP diet, which is a diet low in fermentable carbohydrates, is also a common one, and there are some resources that I've got on the slide where you can get some really good information about this diet. And our patients with irritable bowel type of symptoms, particularly with bloating, pain, and diarrhea, are usually quite responsive, but I find it helpful even in patients with constipation who have quite a lot of bloating and abdominal discomfort. And in combination with laxatives, this diet can still be helpful. Patients with mast cell activation disorder often have been advised to go on a low histamine diet. The jury is still a little bit out, but certainly it is worthwhile looking at histamine-related triggers. The histamine diet itself is a very strict diet, and it can produce nutritional deficiencies. And all of these diets are not meant to be forever. They're meant to be for a period of time, 4 to 6 weeks, and then you should go through a reintroduction phase to see what your key triggers are, so that you're not avoiding foods that you don't have any problem with. And all these diets should really be monitored by a good senior dietitian who's comfortable with administering these diets. And of course, sometimes in food allergies, food intolerances, antihistamines and mast cell stabilizers, particularly those patients who overlap with mast cell activation disorder, these can be helpful. In patients with POTS, we often advise lifestyle and dietary modification, especially those who have more rapid gastric emptying and they develop this post-meal hypoglycemia, which means their blood sugar drops, which can happen as a response to rapid emptying of the stomach into the small bowel, and then the blood sugar goes up quickly. That causes a sudden rise in insulin, which then causes the blood sugar to fall back down again, and that can, and it can overcompensate, and you can get a low blood sugar. So we advise our patients to eat small, frequent meals, opt for foods that are low in glycemic index, which means that they are low in refined sugars, and we ask them to increase the fat and protein intake, which also balances the energy requirements, but fat in particular, healthy fats like olive oil, etc., can also slow stomach emptying down. I usually advise them not to drink about half an hour before and after a meal, because liquids can very quickly flush the carbohydrates down into the small bowel. That can produce early or late dumping type of symptoms. Lying down for about 30 minutes after a meal sometimes can help some of these POTS-like symptoms, and just increasing salt and water intake can be helpful. And pharmacological therapy of managing POTS in its own right can be helpful with these tummy symptoms after a meal. A small proportion of our patients need help with their nutrition in the form of enteral or parenteral nutrition, so either feeding through the bowel in the form of nasogastric or nasojejunal tubes, and sometimes direct feeding into the tummy cavity through a PEG or a PEG-J or a jejunostomy. But there is a high failure rate. Infections are common. Pain at the site where the tube is input in is common, and therefore one has to consider these options very carefully. But other issues like POTS, mast cell activation disorder, small bowel bacterial overgrowth is worth looking for in these patients, but sometimes treatment of these can improve nutrition. And of course, sometimes some of our patients can get just scared of eating just because of the amount of intolerance and symptoms they get with the foods, which can produce anxiety and depression. And there's a very, very small percentage of patients who overlap with eating disorders as well, or perhaps restricted eating, and that needs to be recognized and managed appropriately. We generally ask our patients to avoid painkillers, particularly opioid painkillers, because they can slow the gut down, and that in a inherently sluggish gut can cause quite a lot of problems. For treatment of a sensitive gut, which we often describe as visceral hypersensitivity, if there is a sensitivity of the nervous system, then there are medicines like gabapentin, pregabalin, amitriptyline, SNRIs like duloxetine, etc. These are medicines that are used in treatment of chronic pain, but they also help with anxiety and depression, etc. as well. And if there is an overlap, these medicines can be quite helpful. And of course, psychological approaches of cognitive behavioral therapy, hypnotherapy, slow deep breathing, and serotonin reuptake inhibitors like citalopram, etc., all have a place in the appropriate patient. So every patient needs to be assessed in detail to decide what the best treatment option would be. For treatment of constipation, managing with diet alone by increasing the fiber content, but this increase in fiber content often produces bloating. There are simple laxatives like pegylated solutions such as Movicol. There are many other preparations as well that can help to soften the stools and make them easier to pass. If sometimes we use stimulant laxatives as well, either in combination with a softener like Movicol or on its own, such as Senecot and Dulcolax. If constipation is more severe, then what we call prokinetics. These are stimulants for the large bowel. The most common one is Resolor, And that can be very helpful in patients who are resistant to treatment with other conditions. Glycerine suppositories, these are those patients who have a lot of difficulty with evacuation, and suppositories sometimes can be helpful. Linzess is another treatment for constipation, which is reserved for moderate to severe patients, and it acts by releasing fluid in the small bowel, so it softens the stool, but also has a stimulatory effect on the bowel as well. However, because it releases fluid from the small bowel, I tend not to prescribe it in my POTS patients because this medicine can lead to a drop in blood pressure sometimes. And I've mentioned before as well, biofeedback in surgery, our treatment options. Biofeedback is when you go and work with a specialist nurse who assesses the pelvic floor function, and then through feedback provided through just recordings of the pressure you generate in the back passage and how you can improve that, and a range of pelvic floor exercises can help. And very occasionally we need surgery for severe constipation patients where medical therapy has completely failed, but we try and avoid this as much as possible. Probiotics, there's a lot of mention of probiotics in literature to treat gastrointestinal symptoms, particularly irritable bowel syndrome. There are some probiotics which have been shown to have efficacy, and there is data to back it up. The most commonly used ones are Simprove, which is where most of the data exists, but Biocult and Alflorex also have good data to back them up for their efficacy in bowel symptoms. So those who have unhealthy bacteria in the gut, small intestinal bacterial overgrowth, we sometimes use probiotics in these patients, but also to help improve gut bacteria, low FODMAP diet has been considered to be helpful. Sometimes in patients with significant small intestinal bacterial overgrowth, which has been diagnosed in the form of a breath test, we can use gut-specific antibiotics such as rifaximin or neomycin, and very occasionally general antibiotics can be used as well for these patients. So just really to summarize that EDS is really a multi-systemic condition, and therefore we need a really multidisciplinary approach to manage our patients, and we need commissioned services, which sadly do not exist at the moment. So we really have to form your own team. And just at the end, just to thank various colleagues who've been very helpful over the years with the research that we've performed, and also our funders, particularly the Ehlers-Danlos Society, have been very generous with the funding, and this has been very, very helpful to take our program forward, and also the EDS UK. Many thanks indeed.